Hi guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, today I was in a neurosurgery theater. So we had this kiddie that 9-year-old that the neurosurgeons, they wanted to insert a VP shunt. So the child has got hydrocephalus. So I want us to talk about that case, our anesthetic approach to that case. So, this is a neurosurgery case, and this was a 9-year-old where so they wanted to insert a VP shunt on this kiddie. So what was our anesthetic approach to this patient? Guys, this is very important. This is very important. They will ask you, it's going to come. They will give you different scenarios. They will ask you, what's your approach to this patient? So that's why I'm doing this, talking about the cases that we had. I want you guys to appreciate the anesthetic approach to different cases so that you can know, okay, if we've got a BKA, what's the anesthetic approach? If we've got a neurosurgery patient, what's the anesthetic approach? If we've got acute abdomen, maybe they've got the patient's got appendicitis, what's the anesthetic approach? Because that's what's going to come, so you need to know. And also this is important even during internship, that when a patient comes in, you need to know what is the sequence of events. Anesthesia is very strict in terms of sequence of events. When I say sequence of events, I mean what you need to do after what you have done. What drug do you need to give after? If you have given drug A, what should be drug B? What should be drug C? What should be drug? Just like that. That's just how it is. So there's a very, like, the way anesthesia is just too structured. It's very structured. There isn't really a room for chaos there. So you need to know. For instance, if you've got 5 drugs that you need to give, and you're gonna give them in this sequence A, B, C, D, E, the minute now you take B and make it A, or take C and make it A, you swap them around, problems are gonna happen. So let's jump into it. So neurosurgery case, 9-year-old with hydrocephalus, the surgeons wanted to insert a VP shunt. So what did we do? Like I always say, an anesthetic approach to any patient is as follows. You need to do the pre-op assessment. You need to know what you're gonna do intra-op. You need to know what needs to be done post-op. So this is a complete anesthetic approach to a patient. But what we're going to be talking about in this case, we're going to be focusing on intra-op. So whenever someone asks you what's your anesthetic approach to a given scenario, you need to know, okay, pre-op I will do A, B, C, and D. Intra-op I will do A, B, and C, A, B, and D. And then post-op I will do B, C, and D. Just like that. So, and I've always and I've tried to explain this nicely, that when you've got a intra-op, when a patient comes in, so the patient will come in, you will transfer the patient from the stretcher onto the table. Once you have done that, first thing that you're gonna do is you're gonna attach monitors. Guys, this is very practical. We did this for this patient. Attach monitors. The monitors that we attached, NIBP, non-invasive blood pressure, the pulse oximeter, and the ECG leads. After that, obviously, you never do anesthesia alone. While one person is doing is attaching the monitors, another person will be inserting an IV line. So this is very important, guys. This is a 9-year-old, right? These are the differences that I want you guys to appreciate. When it comes to the pediatric population, you don't insert an IV line while they are awake. You must first induce them. So what we did, we made sure that this is fine, and we have got all our drugs and all our equipment ready, because we knew that we are gonna do a GA on this patient. I mean, operation in the head, that's gonna be GA all day. So what we did, attach the monitors, get our readings, and make sure that we are getting nice readings. Then blood pressure is normal, we are getting nice sets, ECG tracing is also good. Now the next thing is that we induce the patient. Induce the patient with a gas, and that gas is SIVO. This is one of the differences when it comes to the pediatric population and adults. With adults, you don't induce them with a gas. You use an IV agent. But with the kiddies, you use sevoflurane. The reason why you use sevoflurane is because when you compare sevoflurane with other gases, it has got nice properties that makes it to be an inhalant of choice when it comes to the pediatric population. And one of them is that in terms of the smell, apparently it smells much nicer than the other gases, and it's less irritating to the airway. So they talk about a pungent smell. You see, you don't want to be asking a kiddie to be to inhale a gas that is like smelling, that's got a bad odor. They will take it out, they'll be restless, they'll start crying, it's gonna just be a chaos. So you use sevoflurane for induction. Now, once the kiddie is sleeping, now you'll start to insert an IV line. So you can poke this child and poke, they won't be feeling any pain because they are sleeping. Now, after you have done that, now you get your line, you will give them now a drug that will blunt intubation response, and we use fentanyl. If you have been following my videos on anesthesia, you will know what an intubation response is, and you'll know what are the drugs that are used to blunt an intubation response. Like I've always said, that when you want to blunt an intubation response, the drugs of choice is, when you want to blunt intubation response, the drugs of choice is like we've used fentanyl here, which is an opioid. You can use magnesium sulfate, especially when someone has got PAH, they're already on magnesium sulfate. You can use I've just learned that you can also use propofol. You can use lignocaine, and I've also just learned that you can also use beta blockers, short-acting beta blockers, and it makes sense. because when you've got a stress response from intubation, you get a lot of catecholamines, and those catecholamines, they go and stimulate your beta receptors, and then that's how you get your high blood pressure and your tachycardia. So it makes sense that beta blockers are one of the drugs that can be used, but they say short acting, and you can also use that local anesthetic spray. Yeah. So fentanyl was used in this patient, and then the next drug that was given was propofol. Right? So propofol was given here as an induction agent. So now we talk of co-induction because we did give Sevo earlier on to induce the child, to make the child to sleep, and then we are further giving propofol. So it's a co-induction. 5, 6. Then after giving propofol, child now was sleeping, and then we gave cis-atracurium. Cis-atracurium, if you have done your muscle relaxants, you will know that it's one of your benzyl isoquinolines, and it's an immediate acting. It's just a cousin of atracurium, so they call it Nimbex. So now this says the job of a muscle relaxant. This is an induction agent. This is a blunting drug, blunting intubation response. This is also an induction agent as well. So when you have given a patient so after giving cis-atracurium, we had to wait for about 3 minutes before we could actually intubate. Right? After intubation, you confirm it. You confirm placement, and then you secure. After securing it, so you connect the patient to the ventilator. So this is the sequence of events. So what I want you guys to appreciate is that I want you to take a note of a couple of things here. So the first thing is, if you look at this, that's why I was saying to you guys that just look at one sequence of events, sequence of giving drugs and all of that. Just understand one and then use that as a template. Because if you understand this, most of these things do not, they change here and there when it comes to the other cases. Now, if you're doing, let's say now you are doing an abdominal surgery, it just differs there and there. So one thing that I want you guys to pay attention to is, one, this is a kit. So after attaching, we induced. It's the first thing. Whereas in adults, you don't induce without inserting an IV line. You must insert an IV line first. I mean, the old population or the older population you can negotiate with them, and then you can they can actually take the pain of you trying to find that line. So, and then after that, if you pay attention here also, here we didn't use saxmethonium. Saxmethonium is not really used in kids, but if this was a different case, we were still gonna do this because we're not doing a rapid sequence here. And there's no cricoid pressure here that we applied because we're not doing an RSI. This patient was fasted, so there was no risk of aspiration. So if it was a rapid sequence, we would have used sax to start with. Secondly, so we wouldn't have used Limbex or cis-atracurium. And also, we would have done cricoid pressure if this was a non-fasted patient. But this patient was in the ward. Actually, I'm the one who went and did his pre-ops. Luckily for me, it was an easier pre-op because pre-op, a pre-op becomes difficult when there are problems. Sometimes they're just straightforward. You look at the drugs that they are taking. Like, it becomes complex when it's a patient that's got comorbidities and a patient that is sick that has got other things, but this one just didn't have problems. So make sure that you can master this. So guys, I'm sorry to make an audio after I've done a video, but just to make sure that we're on the same page. So one thing that I forgot to tell you guys is that, remember, intra-op, you need to induce anesthesia, you need to maintain anesthesia, and you need to wake up the patient. Those are the three parts of intra-op. Yes, you need to also in between to do intra-op monitoring. That's okay. So when it comes to maintaining the patient, until you have induced them, no, you wanna maintain. You wanna keep them on that unconscious state where they are not feeling pain, where they are relaxed. So we used isoflurane after we had connected our patient to the ventilator. So we switched from sevoflurane to isoflurane to maintain anesthesia. But remember, I said that for induction, you want to use Sevo in the kiddies because of the properties of Sevo. But now when the child is already induced, is now sleeping, now you can switch to isoflurane, but don't induce with isoflurane. That's what I wanted to say. So the muscle relaxant that was used was an intermediate acting, which is cis-athacurium, which is an isomer of athacurium. So, and we know that they take about 40 minutes to, like, their effects, they last for about 40 minutes, and the procedure was less than 40 minutes. And also the other drugs that were given, antibiotics, I didn't put them there, antibiotics and a morphine for pain. And yeah, but I didn't want to put a lot of things now. I wanted you guys to grasp the most important things, then we're going to talk about other things as we go. I hope you enjoyed this. Thank you.